Welcome Dr. Lo Man Wei from Hong Kong, talking about treatment of PD infection and complications.
Good morning, everyone. I hope you stay strong and healthy when you are watching this video. It's a shame that I cannot attend the conference in person because of the Wuhan pneumonia outbreak. I would like to thank the organizing committee for inviting me to do this talk today. I'm Dr. Lo from Hong Kong and I'm a nephrologist. The title of this talk is Treatment of PD infection and complications. It's a very broad topic and it's not possible for me to cover every details in 15 minutes time. So the talk today is not meant to be comprehensive and I will just give the principles and directions for treatment of such infection. And I hope you enjoy the video. First, I will talk about the peritonitis, followed by exercise infection and tunnel infection. Before I talk about the treatment of peritonitis, I would like to spend some time on making the diagnosis of peritonitis. The following are the features of CAPD peritonitis. The first one is the clinical feature of peritonitis, and this includes abdominal pain or cloudy dialysate. The second feature is the dialysate effluent under the microscope, and it will show the white cell count more than 100 per microliter with more than 50% polymorphonuclear cells. The third feature is the positive dialysate effluent culture. So if a patient satisfies at least two of the above features, a diagnosis of CAPD peritonitis is made. We do not wait the culture results available before giving antibiotics because it takes several days, and we'll give empirical antibiotics after the microbiological specimen have been obtained. Antibiotics regime should be center-specific and cover both the gram-positive and gram-negative organism. Gram-positive organisms should be covered by vancomycin or first-generation cephalosporin. Whether or not to give vancomycin depends on the local prevalence of methicillin-resistant Staph aureus (MRSA). If the prevalence of MRSA is high, vancomycin will be preferred over first-generation cephalosporin. For gram-negative organisms, they should be covered with third-generation cephalosporin or aminoglycoside. However, we have to bear in mind that extensive use of aminoglycoside may cause emergence of resistant microorganisms. So the local center should monitor the resistance pattern regularly and adjust the empirical antibiotics accordingly. An alternate regimen is cefepime monotherapy, as it can cover both the gram-positive and gram-negative organisms. Intraperitoneal antibiotic is the preferred route of administration unless the patient has features of systemic sepsis, because it can result in a high intraperitoneal drug level. IP administration avoids venipuncture and allows home therapy. It can be given in each exchange, known as the continuous treatment, or once daily, known as the intermittent treatment. After we started the empirical antibiotics, we have to monitor the patient's ultrafiltration. This is because reduction in ultrafiltration is commonly observed in patients with peritonitis due to the increase in membrane permeability during the peritonitis. In such case, Temporary use of higher tonicity of PD fluid or icodextrin may be needed. And once the culture results and sensitivities are available, the antibiotic therapy should be modified to a narrow-spectrum agents. The PD fluid should be inspected visually for clearance, and if no improvement after 48 hours, repeated culture should be performed. Concerning the duration of antibiotics, most CAPD peritonitis require 3 weeks antibiotics, except Streptococcus and coagulase-negative Staphylococcus require 2 weeks antibiotics only, and Pseudomonas and Strenotrophomonas require 3 to 4 weeks antibiotics. In most cases, single antibiotics is adequate, except for spice organisms, which require 2 antibiotics. So the spice organisms refer to Serratia, Pseudomonas, endopositive organisms including Proteus or Providentia, Citrobacter, and Enterobacter. The use of 2 antibiotics is to reduce the risk of relapse and recurrence. There are several types of peritonitis. Refractory peritonitis refers to failure of the efferent to clear after 5 days of appropriate antibiotics. Recurrent peritonitis refers to an episode occurs within 4 weeks of completion of therapy of a para-episode, but with a different organism. Relapse peritonitis refers to an episode occur within 4 weeks of completion of therapy of a para-episode, but this time with the same organism. Repeat peritonitis refers to an episode occur more than 4 weeks of a para-episode, but with the same organisms. In these conditions, removal of the tank of catheter are indicated. If multiple enteric organisms are grown from PD efferent, surgical evaluation should be obtained immediately when there is no prompt clinical response. CT scan should be done to identify the underlying intra-abdominal pathology. For antibiotics, we should give IP metronidazole to cover the anaerobe, plus the vancomycin to cover gram-positive microorganisms, and cefotaximine or aminoglycoside to cover gram-negative microorganisms. For fungal peritonitis, the standard treatment is intravenous amphotericin B and oral fusidocin. Intraperitoneal amphotericin B can be used, but they may cause chemical peritonitis and pain. Other antifungals that may be useful for treatment of such condition include fluconazole for Candida, echinocandin for Aspergillus, posaconazole or voriconazole for filamentous fungi. ISPD guidelines recommend immediate catheter removal. However, our center is adopting a deferred catheter replacement approach. The antifungals were given as usual, but the replacement of catheter is performed when the PD efferent clears up. In our case series, 9 out of 11 patients returned to PD after a total of 31 days of antifungal chemotherapy. In case of refractory or relapsing peritonitis with negative bacterial culture, we have to bear in mind the possibility of tuberculous peritonitis. In these cases, the PD microscopy will show lymphocytosis. DNA PCR or peritoneal biopsy can be performed for more rapid diagnosis. For treatment, it involves 4 anti-TB drugs: rifampicin, isoniazid, pyrazinamide, and ofoxacin. In general, pyrazinamide and ofoxacin can be stopped after 2 months, while rifampicin and isoniazid continue for 12 to 18 months. Non-tuberculous mycobacterial peritonitis is rare condition, but they may mimic gram-positive diphtheria. Some of the examples are Mycobacterium fortuitum, Mycobacterium cheiloni, and Mycobacterium abscessus. Treatment regimen is not well established and involves combination of antibiotics such as cefoxitin, amikacin, meropenem, clarithromycin, and doxycycline for mumps. Catheter removal is usually necessary. The optimal duration between catheter removal and reinsertion of new catheter is not known. Some observational studies suggest a minimum period of 2 to 3 weeks. But after peritonitis, the reinsertion should be done under laparoscopic or peritonioscopic guidance, where direct visualization for adhesion can be done. And then I will proceed to exercise infection and tunnel tract infection. Exercise infection is defined or diagnosed as the presence of purulent discharge with or without erythema of the skin at the catheter epidermal interface. Tunnel infection is defined or diagnosed as the presence of clinical inflammation or ultrasonographic evidence of collection along the catheter tunnel. To prevent exercise infections, prophylactic antibiotics should be administered immediately before catheter insertion. However, no technique of catheter placement and no particular catheter design have been demonstrated to be superior to another for the prevention of catheter-related infection. There is an exercise scoring system which may help in the diagnosis or monitoring of the exercise infection. In this scoring system, there are several clinical features such as the swelling, crust, redness, pain, and drainage. Depends on the severity, they will score different points. If the patient scores 4 points or above, infection of the exercise is likely. However, we have to bear in mind that this scoring system is developed by the pediatricians and is not validated in adult patients. The empirical antibiotics of choice for exercise infection would be cloxacillin or first-generation cephalosporin. However, if the patient had a prior history of infection or colonization with MRSA or Pseudomonas species, vancomycin or appropriate anti-pseudomonal antibiotics should be given instead. Most exercise infections require 2 weeks course of antibiotics, except for Pseudomonas infection, where the course of antibiotics has to extend to 3 weeks. For tunnel tract infection, ultrasound examination can be performed to look for response to treatment, and a sonolution area of 1 mm thick around the external curve or involvement of the internal curve are associated with a poor outcome. There are several indications for catheter removal. They are, first, refractory exercise infection or tunnel tract infection failed to respond to effective antibiotics after 3 weeks, or if the exercise infection progressed to or occurs simultaneously with peritonitis. Most of the information in this talk were taken from International Society of Peritoneal Dialysis, the ISPD guidelines. This ends my presentations. Thank you.